Good afternoon, everybody. I'll just take a few seconds and wait because I think there are a few people just filtering in to the recording. Today, believe it or not, we're on episode 28 of Soundbites. And just by way of a reminder, all of the previous sessions that we've done are available to watch on demand. But we do want to talk about the previous sessions. We want to talk about today's session. And I am absolutely delighted today to be joined by Judith Scholefield. We're going to talk a little bit today about speech and language therapy and provision after a catastrophic injury, and a bit about social communication as well. Judith, now you probably don't need any introduction to the people watching this session, Judith, but I'm going to introduce you anyway. So Judith's a hugely qualified speech and language therapist with over 30 years of experience of working with adult clients with acquired neurological disorders. She's also a medical legal expert, but more glamorously than that, she's actually an advisor to the BBC, which is glamorous, Judith, you have to admit. So very warm welcome to you. Thank you for joining us.
Thank you.
So because we don't have much time, Judith, we're going to dive in and we're going to talk today, as I mentioned, a little bit about speech and language therapy after catastrophic injury. So we, people watching this and all of us, we're all involved in dealing with people's lives who've been absolutely transformed by injury. And for so many, the rehab process is long and it usually involves a varied MDT. Now, can you explain, first of all, kind of as a basic question, how we identify when a speech and language therapist should be brought in to a team in your experience? And second of all, are there any misconceptions about introducing speech and language therapy at an early stage?
Well, just as a broad overview, the obvious times that you would look to instruct a speech and language therapist would be if they've got communication problems.
Yeah.
The second one would be if they've got actual speech problems. So they may be able to speak in sentences and in paragraphs and in conversation, but their actual speech may be unclear. It may be slurred. They may be dysarthric, and that is when we're looking at speech problems. And lastly of the three is the obvious one as well, is that you would look to instruct one if there's a dysphagia problem or a swallowing problem of any sort.
Yeah.
And by that, I mean even down to looking at something, a very quick screen for a dysphagia problem is giving somebody a glass of water. Can they down it in one drink, in one go? Can they produce successive swallows? So even down to micromanaging at that level, we would be looking to be instructed on these cases. I think, to be fair, it's never too early to get a speech and language therapist involved if you suspect that there's any of these difficulties.
Yeah.
I think particularly the one that tends to be missed is the information processing or understanding difficulties.
Yeah.
Frequently, people are very adept at covering up if they've got an understanding difficulty. They nod and shake their head in the right places. They do everything you would expect them to do to show that they're understanding what's being said. But when you actually get down to it and you assess them, things that sort of might flag up an alarm bell is, for argument's sake, can they follow the instructions of the physio? Can they follow the instructions from the OT? The impact upon that if they are needing psychological help. And the other thing that we get involved with, which I think should be considered when instructing, is that we get involved with mental capacity.
Right.
Because often it can be that people are, an assessment of mental capacity obviously deals and has to accept that the person has a certain level of understanding before you're able to assess capacity.
Yeah.
So those are the key areas that I would say you need to think about for anybody that's thinking of instructing. And it's never too early, because communication is basic to us all.
Yeah, for sure, and particularly important for people who have sustained a brain injury. That, you know, it's so crucial that they're able to communicate their needs properly. And I suppose, Judith, it's right that no matter how early you have somebody in, if they carry out an assessment and they, you know, they can always say, you know, this is a bit, we're in the acute stages here, let's have a look at doing something after X stage, or something has happened. Mm-hmm. So there's no downside to feeling this out in an early stage. The other thing we've mentioned that we're going to talk about is a little bit about social communication. So could you just unpack that for us a little bit and tell us why it's such an important skill for people affected by brain injury, particularly?
Social communication is an area that we look at, but it's perhaps not as obvious as the other areas that I've mentioned. If I tell you that it affects around about 70% of people with traumatic brain injury. Wow. So the percentages are quite high. Mm. And I always think of the quote that after a brain injury, people talk better than they communicate.
Yeah.
So when you think about social communication, okay, their speech may be clear, it may be articulated clearly, they may be able to speak in a discourse, but the things that we're looking for with social communication, which in the case of a traumatic brain injury, can affect both social and occupational interactions, which are really important moving forward in the functional environment. Things like, I'm sure we've all seen them, people can go off the point.
Yeah.
Instead of answering your questions, they go around the houses, and then you begin to wonder what my question was in the first place. Yes. Things like eye contact. Do they make eye contact? Talking too much and not turn taking, which places more, as we say, as SLT says, more of a burden on the communicative partner or the listener.
Yeah.
The proximity to somebody when they're speaking. Are they too close or are they too far away? Are they really in your face in terms of proximity and in your personal space? Self-disclosure. The traumatic brain injury who goes out there and gives out information about themselves that's not appropriate, maybe standing in the bus queue to a group of strangers they've never met.
Yeah.
Expressing and recognizing emotion in others. People who do not recognize that what they've said has perhaps upset the listener, but not recognizing that and not altering their communication to reflect that they have understood and appreciated that they've caused some distress to the listener.
Yeah.
Humor, recognizing abstract humor, and things like concrete thinking and not thinking in the abstract. And although, as I say, these are communication rather than talking, but it can make all the difference between making successful social contacts and friendships, and being accepted either in the voluntary or the paid workplace.
Yeah.
Because they intend to be the one person that's on the fringe of the circle.
Yeah.
Because people know that their communication is not quite right, but they can't put their finger on it.
Yeah. And all those communications that you meant, they're so important for people after brain injury who don't feel like themselves and their family don't feel like they are themselves. And, I can see from what you've said the importance of social communication. And you've touched on this already, but talking about understanding and kind of assessing understanding in people affected by brain injury. How do we assess that? How do we assess understanding, and how common is it for speech and language problems particularly to be missed?
I find it's quite common for it to be missed, and more often than not, it tends to be downplayed.
Yeah.
So I get a referral through for somebody, and they might say, you know, the obvious ones are like the difficulties with word finding, and maybe the slurred speech. They're the obvious ones. But more often than not, when we get out to assess them, you find that there are understanding problems, there are processing problems. And these are ones that have not become apparent. It's the word finding problems and the slurred speech. And the problems, you know, forming the sentences are what people pick up on.
Yeah.
Not the processing problems that tend to be more hidden.
Yeah. Yeah. It's interesting to reflect upon as a non-clinician as well. You know, someone like me, I'm not a clinician, I'm not medically trained. It's interesting to have those things to kind of think about and look out for when you see that reported anywhere. And we all like to think, don't we, that we would know when we require input from a certain area, including speech and language. But this is something I hadn't really applied my mind very much to until recently, which was whether there's any room for speech and language therapy with, for instance, patients who, PDOC patients, so prolonged disorders of consciousness, patients who suffer with that, or any type of clients that don't necessarily have a brain injury but have some other type of catastrophic injury. Can you just talk about that a little bit? What is there room for speech and language therapy in those types of cases?
Well, when it comes to PDOC, yes, there's very much a role for speech and language therapists, and I mean, that happens to be my own particular area of interest, is the PDOC cases. I think I would like to think that speech and language therapists take the role in PDOC cases, because when you're assessing somebody in PDOC and you may be looking if they're in MCS or PVS, or if they're emerging, then the one thing that you're looking for is consistency and reliability of response. And that consistency and reliability of response can be around answering yes/no questions. Can they answer 6 yes/no questions consistently, accurately? Can they indicate 6 pictures by name consistently, accurately? Can they do something like look and use an object functionally, accurately? And you can appreciate that all these things are what speech and language therapists are trained to do. Yeah. And I'm brought in on a lot of PDOC cases where they're wanting to know, is this person really in PDOC? Or and are they emerging? Or are they in MCS? And is it MCS negative or MCS positive? And a lot of it is actually around communication. And is it consistent? And is it reliable and reproducible that makes that definition along that continuum? You mentioned clients other than acquired brain injury. The other area that seems to be emerging is that, and obviously dysphagia is for discussion at another time, but we are getting increasingly involved with clients who've got cervical spine injuries, high level, cervical C3, C4. And these are the ones that it would appear from the research that's coming out, and it makes sense that these can have quite significant dysphagia problems. So, you know, we can have spinal injuries where they have dysphagia, but not communication difficulties. So there's a bit of a mixed bag there, but yes, we do get involved with those, and we've had a number of those through.
And it's always worth thinking about at the beginning of these cases, as you say. As usual, we're out of time far too early. And as you said, Judith, it would be so great to talk about dysphagia. We just don't have enough time. There's a whole separate session. So maybe I'll drag you back and we can do a separate session on dysphagia. But thank you ever so much for being with us, Judith. That was really, really interesting and some really important stuff to think about and to take away. So thank you. Just for anybody that will be joining us next week. Just to let you know, we've got Nikki Maple-Pearson, who's guest hosting next week, with Lindsay Harrison and her colleague Claire from Clarion, Claire King, who'll be talking a little bit about identifying financial abuse in catastrophic injury cases and protecting clients. So please tune in for that, and we'll look forward to seeing you shortly. Thanks again, Judith.
Thank you.